Record. All right. Thank you, everybody. It is Power of Patience, our webinar Wednesday, and we have a great guest today, Paul Yulucci, and he is a doctor of physical therapy. He's also a professor at Johnson & Wales, and he has a really, really interesting technique that he's going to teach us all about through his physical therapy, as well as a clinical trial that he's running. So without any further ado, Paul, go ahead and take it away.
Thank you, Lynn, and I really appreciate the opportunity to share some of this information to you and to your members and to the folks at large, and I'm really excited about this. I'm going to talk to you a little bit about what has been my passion for the last 10 years, which is a form of concussion, which is called cervicogenic concussion. It is something that I have been very, very excited about for many years now, and I'm hoping that you folks will also be equally excited about it as well. So we're just going to go over the learning objectives. It's the old professor and me have to do this. So really want you to be able to recognize the cervical spine's role in the development of concussion and post-concussion like symptoms. And we put those in quotes because it's not a concussion. And I think that's the first thing that I want to make clear. And then we want you to be able to identify, from a physical therapy standpoint, athletic training standpoint, what is the best evidence-based procedures in order to identify when these symptoms are not actually caused by your brain, but rather by your neck. And then finally, how do you treat it? What's the best way? What has been shown through evidence to be the most effective way to address these symptoms? So, most folks, when they think of concussion, they think of the myriad of things that happen during metabolic cascade, which occurs after an insult to the brain. During a traditional, or what I like to call a physiologic concussion. There's an impact to the head or brain, in which the brain now moves back and forth within the skull. This causes an insult, usually some type of bruising or otherwise insult to the brain itself. This sets off a metabolic cascade, which I think many of you are familiar with, and many of your physician friends and medical colleagues of mine really focus on this physiologic concussion. And you can see there's a lot of research here. We know which parts of the brain, when they are affected by a physiologic concussion, what symptoms you'll actually exhibit. For instance, if you have a memory issue, it's most often integrating sensory input, or vision or loss would be in the parietal area. Visual changes are in the occiput. We have auditory changes or hearing issues and balance issues on the temporal lobes, which are on the side of your head. Decision-making is also influenced by the frontal lobe. What's important to think about, though, is that many of these things or these symptoms can also be brought on by other areas, whether it's the vestibular system, which we're not going to talk about today, or actually the cervical spine. So we're going to get through that slide real quick. And this is what I want. The first thing that I brought my attention to my first client was that they were reporting signs and symptoms of pain that were not really what I see with someone with a physiologic concussion. I see it more with something that's involved with the neck. So for your viewers, I wanted to include a very simple slide of areas of the head and face that are likely to have referred pain to when you have a headache or migraine caused by the joints of your neck. And many of you who have had a concussion have similar sources of pain. Now, this next slide depicts the muscles of the neck and head and where they refer pain to when they are irritated or inflamed. So again, we have many people with concussions complaining of pain in this area, that temporal area of the head, people with TMJ over here in the jaw, and then the suboccipital region. Boy, I'll tell you, this really lit up my first client when I looked at this, and he was having pain here and here, and then he would report this type of pain here in his face as well. And that's what really clued me in. I said, this is not that generalized headache and that constant all over migraine sensation that people most often feel when they have a physiologic concussion. So that was the first thing that clued me in on this particular individual's problem not being an actual physiologic concussion. And that's something I could actually address directly, which was his neck. So here's our neck. I cut out many of the slides I would normally show our medical professionals due to the graphic nature, but I wanted you to get an idea of what's actually going on in your neck and what's going on inside your skull. This here is the bottom of the skull itself, the basilar area. And the brain sits right in this space right here. The brain stem extends down here into the area below the foramen magnum. And here is the actual attachment of the first cervical vertebrae and the second cervical vertebrae. Now, when I first got involved thinking about cervicogenic concussion, the only area of the entire spine that I was worried about was these two little joints right here between 1 and 2 and the occiput and 1. I really was restricted to just thinking that was the only thing that could cause these symptoms. I've since learned, and certainly the literature has proven, that it is far more extensive than just C1, C2. And we'll talk more about that in a few seconds. So we can't think about the neck without thinking about all of the muscles and ligaments that are attached there. And without getting into too much detail for folks, again, with that emphasis back in the day of this just being an upper cervical problem, I really spent a lot of time focusing on this suboccipital triangle that's located right here. The reason I was so focused on that suboccipital triangle was because that's what the literature was talking about 10, 15 years ago, and because of the presence of the vertebral artery. This red structure here is actually a vertebral artery, which is housed inside the transverse processes of the cervical spine. Then it comes out and then goes up into the actual vault of the skull to supply blood to the bottom of your brain in the circle of Willis. And then we have this nerve here, which is the greater occipital and the recurrent occipital nerve, which is often associated with pain patterns that are depicted in those previous pictures that I gave you earlier in the slide presentation. So again, that early focus was on this upper cervical spine. We had an anatomical reason for this pain and discomfort, and we had muscles and nerves that we could associate with this problem. So the dorsal ramus of the suboccipital nerve is going to supply the back of your head. The suboccipital venous plexus drains the blood out. And then, of course, the vertebral artery supplies blood through the circle of Willis to your actual brain. So expanding upon this, we then started looking at more and more involvement in the neck, and we started realizing that athletes who had weakness in their anterior muscles of their neck, or the neck, deep neck flexors, these folks here, the capitis, the longest coli and longest capitis, if they had weakness in that, they were more likely to get a concussion, and they were more likely to have be implicated with weakness in that area. So again, I started saying, okay, so maybe it's not just C1, C2, let's look deeper. And lo and behold, at this point, the literature is suggesting that we need to look at all of the muscles, particularly the deep muscles of the neck. So longest capitis, longest coli here in the front, the deep neck flexors, for some of you who've heard this in the literature before, the scalenes here, and then the semispinalis. All of those have direct innervation. We're going to show that in a few slides, to areas of the brain. So we started expanding the research, the anatomical research, and then other clinical research kept expanding. What is an actual cervicogenic concussion and what can be involved in it? You know, a lot of this comes out of the work that started in 2015 with Ellis, who developed this paradigm to determine whether or not a person had a physiologic concussion, that metabolic cascade that we talked about earlier, or if there was something going on with their vestibular ocular system or their neck itself. Now, please keep in mind that even in 2022, there are people who don't believe that the neck can cause this symptoms, even though there's a tremendous amount of literature, and you'll see it at the back of my slide deck in the references, that does indicate it. So there's a lack of awareness. And in fact, one of the studies that I'm currently doing right now demonstrates that well over 50% of practitioners are not using an evidence-based approach to analyze people for the presence of cervicogenic concussion. So this is the first work that came out in 2015. How do we striate this? Is it physiologic? Is it vestibulo-ocular cervicogenic? And again, you can't think of it just that simply, because the neck is going to essentially directly influence function of the vestibular system. So when we look at this other slide, they were asking us to say, is it the neck or is it the vestibular system? Well, folks, if the neck has input directly into the vestibular system and the part of the brain, that interprets signals from the vestibular system, then it's going to influence the vestibular system as well. So again, a major impact here is the fact that the neck has input directly to the brain, as you can see from this arrow, and to the vestibular system, because the neck has to tell the vestibular system where it is in relation to the rest of the body. And that really is a plethora of information that needs to be synthesized very quickly by the brain in order for you to not have symptoms like headache, dizziness, fatigue, insomnia. All of this can be linked to these problems in the neck. Great study came out in 2021 where they actually have linked and found afferent input from all of these structures in the upper cervical spine now, basically down to about C5 is where I feel comfortable talking to people about right now. So the fifth cervical vertebrae, which is pretty low, in fact. And they all have input that can cause dizziness, nausea, headache, and difficulty with concentration. Does that sound like a concussion to you? It does to me, and it certainly did to my client when I first saw this first individual. So we know that the apophyseal joints, which is actually the facet joints in the back of the spine, in your cervical spine, have input that can cause these symptoms. We know that all of those muscles that I described earlier also have input into this system. And then the discs themselves have nerves in the disc themselves, particularly in the periphery now for us anatomical people. And that all sends feedback as to where our head and body are relative to each other, thus influencing what the vestibular system is telling us. We don't lose our balance when we lean forward or we bend our neck, because our neck is telling our brain that the vestibular system has been moved forward, right? Well, if there's a problem, if the system is broken down or too excited in the neck, it's going to give too much feedback to the brain, and we're going to start having the symptoms that we see so often in people with concussion, vertigo, and dizziness. I do put this in here also because the vertebral artery blood flow has been shown to be effective, or excuse me, cause some of these symptoms as well. I'm not going to get into it too much detail today because I am focusing on the neck itself, but this is a picture I think is important to help you visualize when we turn our head, just how much stretch is placed on these vertebral arteries. And just like a piece of spaghetti, if you pull it, it gets thinner in the middle. Well, that narrowing of the lumen of the artery slows down blood flow. And that may also be related, according to Diaz, to some of these symptoms. So I mentioned it briefly because I think it's important for clinicians and patients to know that there are multiple reasons. It could be a muscle injury to your neck, a joint injury to your neck. It could be your vestibular system, but it could also be a blood flow system. And I know some of you have looked at that. We've talked about Doppler ultrasounds for diagnostics in some of the courses that we have coming up. So as a patient, you want to know what's the best thing to do to figure out if I have this neck problem, right? Well, postureography is a very simple process that needs to be done by a medical professional in a specific lab with specific equipment. In 2018, it's been shown to be pretty effective in identifying those individuals who have neck involvement in their concussive-like symptoms. The seated and supine cervical flexion rotation test is a good test that can be done by a physical therapist, athletic trainer, doctor, PA, to evaluate patency or mobility in the upper cervical spine. The cranial cervical flexion test is that deep neck flexor test that we talked about earlier, where we know if we have longus capitis or longus coli weakness, that's associated with increased risk of concussion. But we also know that if that's weak, it strongly indicates that the neck is involved in that person's symptoms. And that was demonstrated by Sung in 2020. De Varha has also described the use of the smooth pursuit neck torsion, which is something that your PA, your AT, your physical therapist, occupational therapist can use. We'll be showing some of these tests momentarily. We'll do a torsion test and head neck differentiation. That article came out by Trey Levin in 2020. Kind of interesting, some really good data there. And another test that we can talk a medical professional through, or they can look up videos and learn how to do it, and then help describe what's going on with you and maybe define that and diagnose you with cervicogenic. Joint mobility testing of the cervical spine is the last one. It's fairly simple to do if you've been trained appropriately. Basically, a physical therapist, occupational therapist, athletic trainer, doctor of osteopathy, their chiropractor, all know how to do those tests. And that's an assessment of mobility and patency of those joints. And that can be useful to really identify areas to treat, as well as the involvement of the spine. We discussed the supine and seated flexion rotation test. That is the gold standard for looking at that C1, C2 mobility. And that was actually the spawn of at least 3 different research projects for myself, a couple of which got published, which was a lot of fun. But it's a very simple test to do. I'm going to show you a video of someone having it done on them. And again, the key here is that this is not complicated and performance of activities. It's learning how to do them and then doing them appropriately, and then getting that information and using it to make it an appropriate diagnosis. So let's look at this test. Patient lies on their back. The clinician lifts their head up, tries to get the chin as close to the chest as possible, and turns the head left and right. And they're looking for a difference in symmetry of 12 degrees or more in one direction. So if you've lost 12 degrees of motion in one direction, that indicates that there's a problem with C1 and C2, okay? And that can be easily, and I do mean this, easily addressed by an athletic trainer, physical therapist, chiropractor, DO. It's not hard to do, folks. It's very easy to do. This is the seated version of this test, and colleagues and myself were able to demonstrate that this is equally as predictive as the supine for AA and OA involvement. So again, same idea. You're looking for asymmetries more than 12 degrees. If you do the math, really, the head should rotate about 45 degrees in each direction. So it's kind of easy for us as humans to see half a 90, right? So 45 degrees is pretty straightforward. And if you see a difference of 12 degrees or more in either direction, then that is indicative of mobility restriction that you then need to address. So again, you're not seeing any fancy equipment right now. You're not seeing expensive techniques. You're seeing someone who has some skill development with their hands and confidence enough of the patient to allow them to turn their head. Now, this should not cause pain. This should not cause irritation. It really is as benign as I'm describing. Here's another test. I do suggest that perhaps this is not the best test, but we see it a lot here in Rhode Island, people doing this repositioning test. The data's on this is a little bit iffy, and basically what you're trying to do is focus on an area with a laser on your head, and then close your eyes, move your head back and forth to disrupt your sense of where you were initially, and then see if you can get back to it. And you can see that it comes with this really cute little target for you that's color-coded and everything. Depending upon what the data shows, if it's really off, it's out in the yellow and the red, it might indicate that you have some issues with neck repositioning. There is, however, a lot of variety here, and we've been doing a lot of baselines on our PT students, and it's not as good as we would prefer. Let's just put it that way. We were doing a study to kind of validate it, and it basically fell apart because we couldn't. But a lot of folks are still using that test, and I'd rather see them use the other tests or some of the other ones that we're going to talk in a minute. So how do you treat it, right? If you're on this line right now and you're here because you have concussive-like symptoms, or a loved one has concussive-like symptoms, and you're not getting better, and you want to get better, right? You need to get better. It's easy enough to have a physical therapist, again, athletic trainer, DO, chiropractor, do this assessment on you. And then once they do it, the treatments are straightforward manual techniques that work. I mean, the literature actually suggests that just having soft tissue mobilization, i.e. massage, will reduce headache, pain, and actually concussive symptoms. So that was another clue that addressing the neck directly will reduce signs and symptoms of concussion, i.e. concussive-like symptoms, and help people recover. So we know that the massage works. That was a nice article by Burns in 2015. We know that some joint mobilization techniques called snags has been shown to work multiple times in 2021, 2015, and 2014. What's interesting, folks, about this 2021 article is this technique involves essentially overpressure of a joint and having some active movement to restore mobility in these individual joints. A follow-up 6 months after the initial study demonstrated that it was still effective in eliminating or minimizing symptoms. So I want you to think about this. If you are symptomatic, it is worth getting the evaluation because there's literature that actually supports 6 months of recovery from a simple technique performed during a research study. Reese in 2015 showed that the Maitland-Mob technique, again, is certainly available and useful. Muscle energy technique will restore joint mobility and certainly is got some backing. We are in the process of proving this and getting an article out on that. You've got to do your exercises to maintain the mobility. So it's all about neuromuscular re-education, stabilization, stretching, and facilitation, and then the regular traditional mobilizations that we would see in physical therapy, which is the grades 1 through 4. And then the high velocities that you would think about in chiropractic or advanced physical therapy manual mobilizations, again, has been demonstrated in 2021 to be effective, okay? So these are direct treatments to the neck that eliminate or reduce symptoms dramatically for patients. I'll put this up here for our clinician friends and move on. Look, if you have any of these conditions, there are reasons why you shouldn't have some of these treatments done, okay? We're gonna hope that none of our folks are dealing with any of this, but there is some issue here, particularly with those with Down syndrome, because Down syndrome has been demonstrated to have laxity in the upper cervical spine, and we certainly don't want to be doing any high velocity manipulations or joint mobilizations in the cervical spine on a patient with Down syndrome because they're at risk of significant injury if we did that. So we stay away from that. So let's talk about this. Have you ever had these symptoms relieved by these simple techniques? Have you ever had a clinician or a spouse or a loved one just simply pulling on your head? So this is a view from the bottom. We have a person on a table with a glass platform. I've got my hands underneath her neck. And you'll see what I'm doing is I'm essentially pulling the connective tissue towards the skull and then maintaining what we would call inline traction or cervical distraction. And this relaxes all of this connective tissue. And I do want you to think about this from a clinician standpoint, particularly for my physician friends. That anatomy stuff sometimes has been a while ago. And I want you to think about all of this white connective tissue. It's not just that nice muscle that you see on this neck. I want you to think about all of that connective tissue and how much input from that connective tissue is going to influence your patient's symptoms because of that direct input. Here's a young lady from California with observable tightness in her scalenes. And this is just a very simple way to assess it. I'm just moving the head and I'm not putting her on stretch. I'm literally just demonstrating, look at that fascial tightness. All of that is going to lead to neural input into the brain that can cause some of these symptoms. How do you treat it? Well, easy enough. This is how you treat it. Very simple soft tissue technique that a good massage therapist can employ to basically work on having those muscles relax by doing longitudinal strumming or cross fiber strumming, and then adding stretch. I really don't want to hit the link because it'll probably throw off the video. But this is a snag technique for clinicians. It's a very simple technique, which has been demonstrated time after time here, 3 different published articles, one with a 6-month follow-up to address the mobility of the cervical spine and like I said, eliminate or reduce the symptoms that the patients were having. These patients were having concussive symptoms, and they were thought to have concussions, cervicogenic concussions. Here's a little technique that we use from a muscle energy standpoint to address mobility in the upper cervical spine. Pretty old video. I must have made this 10 years ago. But again, it's very similar to that supine cervical flexion rotation test. Maximally flex the head. We engage the barrier where it doesn't want to rotate anymore in a minute. When we go in this direction right here, you'll see that he doesn't want to move his head to the left. In fact, it doesn't move to the left. So at this point, what we do is we use very gentle resistance. I use my pinky because I'm a big guy. I'm a 300-pound individual. So, and I got some muscle. So I use my pinky, or in this case, one of my fingers, to just demonstrate it. And I have him look with his eyes. And the reason is because I want him to use the small little muscles that I showed you before to get this to work. The more I force him, the less likely I am to be successful. So it's literally a technique where you use just enough to get the job done. It's usually like a pinky or just a finger, and you ask them to move their eyes, because the eyes will, when the eyes turn, they fire those little muscles in the suboccipital triangle that we looked at earlier and get the connection there and actually make the joint move for us. Same idea, just in the supine version. Again, clinicians don't compete with your patient. Let them win. And when you let them win, they'll win and they'll actually feel better. And these are my, these are the references that we have here. I'm going to try and go back, and Lynn, if you can help me out, if I mess this up, just let me know.
Okay.
Just wanted to show this technique because I think the most important thing here, and are you seeing YouTube pop up right now?
It is trying to pop up.
Yeah, JWO internet, yay. I did this at UConn earlier, and it was a similar slowness, but here we go.
Okay, yeah, it's coming up.
Probably has the best accent of all YouTubers ever.
Where is he from?
I believe he is from New Zealand.
Oh, okay.
You don't have the audio because I forgot to share audio. All right.
Oh, okay.
So he's demonstrating basically the technique using a strap to actually do the mobilizations. And what's important here is this strap, you're holding it to stabilize the neck and the joints in space. And then you're using your own muscles to move your head to get the mobilization. It's very, like I said, you know, it's very simple stuff, but it's incredibly effective. And again, demonstrated to truly have some long-term results for patients. So I hope that was.
Yeah, that was, I think that was fabulous. So I want to ask a few questions. And of course, we always open this up to our audience as well. You used some words that maybe not everybody is actually familiar with. And so the first one in the very beginning, Paul, you were talking about evidence-based practices. And so that is something that I think, you know, when people are discussing clinical, and I love your graphics, by the way, like I'm like totally geeking out on these graphics, but can you describe to everybody, what does it mean to be evidence-based?
Yeah, I think it's the buzz term for most medicine now. It's been this way for about 10, 15, maybe as long. I'm actually old, so it's probably about 20 years now, where what we're supposed to do as clinicians is look at the literature and identify where our patients' symptoms match what the literature suggests, and then what testing and other applications are important to help us guide us through the process of diagnosing the patient. And then once we've diagnosed the patient, we then go back to the literature and say, okay, what's the best course of treatment to maximize recovery at the shortest amount of time while reducing risk and things like that. Now, the most important concept, in my opinion, is actually one of the pillars of evidence-based medicine is what patient preference is. And I think that's very, very important, is what is important to the patient, what do they believe in, and what will they agree to either undergo or to have done to them or to do themselves. And I think that's a huge part that often gets lost. Now, with that evidence-based practice, there are enough articles out there right now in the literature that describe what is the best way to evaluate someone for cervicogenic concussion. And it's fairly well spelled out in the literature. It's not hard to find. You can easily find it. And in fact, those references contain a bunch of that information. We did a survey, Johnson & Wales colleagues and I did a survey of a number of medical providers throughout the region in New England to identify what is the practice pattern. What are they actually doing? Are they using evidence appropriately to identify the cervicogenic component of concussion? And unfortunately, we're not doing well, folks. We're really not. And we'll run the statistics, and that's going to be hopefully a paper coming out in the next year. And then we'll put on a conference in May where we do a pre and post, and hopefully we can actually show some folks some evidence and show some reason to actually do this, and then actually teach them how to do it directly, manual techniques, and then maybe improve on patient care. That's the mission here at Johnson & Wales.
That's awesome. So another question, I have two more because I want you to kind of, excuse me, dive into your clinical trial. But before you go there, you discussed strength, right? That typically in the very front. And so I have a fused C4, 5, and 6 in my neck. So I'm very keen on everything that you actually showed, the manipulation, the stretching, and it is difficult to find therapists that will actually work on these scalenes, right? And I know that posturally, if I'm too close to the computer, right, I might have slept poorly and my vision is blurred and I'm like really close to the computer, and that throws out my neck. And so it's a lot of it is very much about posture. So maybe you could share or do something to show folks what it means to strengthen those muscles so that you can maybe improve your cervical issues that you might or might not be having.
The best way to do deep neck flexor stretching really requires a lot of feedback, and feedback in the form of a device. So a physical therapist, occupational therapist, athletic trainer, they're going to take a blood pressure cuff or something that looks a lot like a blood pressure cuff, and they're going to have you lie on your back on a table, and they're going to put it behind your head and neck. And they're going to use that to give you feedback so that you're trying to engage those muscles without engaging these big, giant muscles in the front. Our sternocleidomastoid, which is the big muscle that when we flex comes popping out, that tends to override and take over for those longus capitis and coli. And what happens is when that happens, those deeper muscles don't engage and they become weak. And then that weakness causes all kinds of problems, and has certainly been related to increased risk for concussion.
Okay.
Now, that forward head posture that you were talking about when you're sinking into the computer, not only does it cause problems with those muscles, it causes them to overstretch in the front predominantly, but then it also compresses the suboccipital space, which is in the back of your skull, right below the bottom of the skull. And that really is really going to irritate the devil out of those muscles in the suboccipital triangle, as well as ligamentum nuchae and a bunch of other fascial areas. That's going to cause a lot of those symptoms.
Okay. That's now I'm paranoid.
It's treatable. You know, the neat thing about suboccipital tightness is I say go cheap. Go buy 2 tennis balls and a big white athletic sock. Put the balls in the sock, put it on the back of your skull, instant traction.
Yeah.
And that's highly effective.
I do that even with those spiky balls, and it's like a miracle. Yeah, I absolutely love those. The second, or I guess the third question, and again, folks, feel free to kind of jump in here. I know you're running a clinical trial. You didn't really kind of talk too much about that, but you've already collected 300 patients data points. You want another 300, so we want to help. How can we, maybe you can kind of give a little infomercial, if you will, about your clinical trial and how we could help refer patients to you. What are you looking for? What is it all about?
Absolutely. So once I recognized that the neck was a problem in concussion, we started looking for data on how often is this actually a problem. So there have been some retrospective studies where they go back and find people who are been concussed for a long period of time, suffering from post-concussion syndrome. And they go back and they look and they find that the neck is involved. And in fact, a recent article, I believe just came out in this year, showed that 80% of those with concussive symptoms for more than 6 months demonstrated some form of neck involvement. So that's pretty dramatic, right? That's pretty dramatic. And it's certainly a patient population who at this point are kind of desperate for, how do I get better? And how do I make this better? And they need a full inclusive, perspective of what's going on, because there could still be some metabolic cascade issues. There certainly is going to be neck issues. The literature says about 80% of them suffer from neck problems. There could be some vestibular issues. There's going to be weakness. So you need to have a very comprehensive approach. But there was nothing looking at those people who are acutely concussed and catching them early, and can we make a change so they never get to post-concussion syndrome, so that they're not 3 weeks out and still suffering? Can we fix this sooner? So that's the clinical trial that we're on right now, is focused on concussion, vertigo, and dizziness. And what we do is as soon as we see you, we're going to assess you for your neck. So that's earlier than what was recommended in the literature, because we think that it's happening at a higher rate and it needs to be addressed. So our hope is to demonstrate that the prevalence is high enough that people will actually take it from something that was originally recommended for 3 weeks and then 2 weeks, and say, hey, let's make sure the neck is okay from a structural standpoint. It's not actually fractured or sprained, ligaments are injured. And once we've ruled out ligament damage or bone damage, let's go look at the neck and treat it within the next 24 to 48 hours to maybe keep them from getting these symptoms long-term and avoid it altogether. So we have 300 folks involved in this study so far. Some of them just have vertigo, some of them have dizziness, some of them have concussion, and or diagnosed with concussion. And we're finding a pretty high prevalence, but I really want to have a high number of people involved in the study so that we can go to a research journal and say, I have solid evidence, I have a good study design, which I do, and my N is so big that you can't turn me away, and we're going to get published. And that's really what we're looking for. So we're looking for patients who have been diagnosed with concussion, maybe concussive vertigo, concussive dizziness, who would like to be assessed for this condition. And then a treatment plan then can be developed by the clinician to actually give to a provider in your area, and actually see if we can resolve this for you. And I think that's really what we're looking to do. And certainly be very interested in having people contact me here at Johnson & Wales, and would love to work with them for sure.
Okay, that's wonderful. So I kind of just want to clarify, do they need to be freshly concussed? What about self-diagnosis? Because as you know, there's only now one diagnostic method from Abbott. It just came out, a biomarker from your saliva, I believe it is, or maybe it's a blood test, but it must be done within 24 hours.
Right.
Many people don't even know they've been concussed, or even a TBI, because it's all under that umbrella, right? So what if they are self-diagnosed? Is that okay? And how far out can they be?
The length of time does not matter.
Okay.
With the study, due to the nature of what we're dealing with, we would at least like to have you seen a physician who's given you some form of a diagnosis, just to keep it within our IRB protocol, to ensure that we're staying true to our study, for sure. So self-diagnosis, not so much, but certainly if you have seen a physician who has told you, look, I think you have a concussion, or, you know, if it's been 6 months, at that point, you don't have a concussion, you have post-concussion syndrome, and you really can be looked at. We need to do that comprehensive approach, you know, and I'm happy to talk to other clinicians. I mean, we're doing continuing ed all the time. The way the IRB is structured, if a clinician in California called me up tomorrow and said, I have a patient with concussion who heard about you and would like to get some information, that's okay. If they want to enroll with the study, great. If they don't, I'll talk you through the assessment and give you some evidence-based guidance on this. And then you, as the treating clinician in California, can then make your clinical decisions and then move forward, but with the evidence and with the knowledge of what is actually going on from a cervical spine standpoint. And yeah, happy to talk to folks about that. And that's really the point of academia, and particularly here at Johnson & Wales, is to promote healthcare. And we'll do that through this Con Ed program in May for physicians and athletic trainers and PTs and OTs. And happy to do it at any time.
Okay, that's awesome. So basically, kind of what I'm hearing, while maybe it's not telehealth where you are remotely assessing a patient, but through your collaborations, and because the IRB has approved all of these collaborative processes, if somebody is in Canada, we'll use Canada, right? You can actually communicate with their clinician so that that clinician will follow your steps in the protocol, in the research paper, what has to be done, and they will then give you that data to then support or, you know, keep shooting for that N of 600 patients.
And,
so
and that would
correct?
be absolutely, and that would be telehealth and at its finest at that point, and a nice collaboration. And I think that's totally something that we can do. Absolutely.
And how many times do patients need to go in? Is it just a one and done where they're being assessed for the prevalence? So patients don't have to continually go, it's just going in. So here's a big one. What if a patient that, and we'll be distributing this to, you know, everyone, what if they say, hey, I want to go see my doctor and I want to have this assessment done? Can the patient initiate that? Because we're about patient empowerment.
Absolutely.
Okay.
You know, I mentioned the part of the patient desire and thought process and evidence-based is an important pillar. And yes, I mean, if you think you've had if you've had a concussive symptom for more than 3 weeks, frankly, and no one's ruled out your neck, then you haven't had an evidence-based assessment for concussion. You just haven't.
Okay.
You know, you may have had a physiologic concussion at one time. You might have had a vestibular concussion, vestibular-ocular concussion at one time. But if no one's assessed your neck and you're still having symptoms, well, there's a great study out this year that says that you got an 80% chance based on a retrospective study. I don't want to nail it, but 80% is still 80%. And I think that's the kind of numbers you don't mess with. I would say you really need to have your neck looked at.
Okay. Okay, wonderful. Paul, do you want to, I do not recall if I saw your contact information on one of the screens there. You want to pop that up and we'll do a quick little check to see if anybody has any questions whatsoever. Don't be shy, folks. Let's see.
Got it right here on that first slide.
Okay, perfect. Yep, it's down here in the bottom. Sharma, did you have a question?
Yes, ma'am. I got like this concussion day diagnosis in August of 2020. And then because I didn't have a full-fledged insurance, I need to go through emergency people. They just told me, go to see some type of neurologist. And then, like after a month or 30, more than 30 days, I found there was a neurologist, I'm sorry, and he did lot of tests on me, and then he found I have a really bad post-concussion or something. But first of all, I'm not the native speaker of English. I'm from Nepal, and my English language is the barrier for communicating to the people. And besides that, I got this type of issue long back in 1998 at the first time. I'm a TBI survivor, as well as right now, recently I face concussion, and now I'm doing post-concussion treatment, basically improving my speech. Communication side, this neck side, I even did not think that much, but I do regular basis exercise.
Right.
And sometimes, yeah, as he mentioned, yeah, it hurts one side, but that goes within couple of hours, it will go. And when I keep on doing exercise, it will goes. And sometimes it comes slowly. But besides, my major issue right now is I am having speech issues. Inside speech therapy, there was bunch of tracks. One of them is short-term memory, one of them is language and the speed. When I speak, most of the people, 60% to 50%, they don't understand. And my clinic therapist told me, slow it down. When I slow it down, at least people understand little bit. And I don't know, this type of like service will help me, or see next side, even I thought minor for my case. Right now I'm working for mostly like cognitive issues. One of them is speech therapy, and inside speech therapy I'm working on memory, task execution, language execution, and speed. How speed I can execute the task. Basically neurotransmitter speed inside the brain. So is any kind of help I can get from your services, any kind of thing you guys do for people who has language barrier? First of all, I have a huge accent. Second thing, I face this type of issues recently, and then my speech is going faster. Only controlling mechanism is not there. When I speak fast, and then people do not understand. But they told me, slow it down. When I do very slowly speaking, I feel myself frustrated, other people frustrated, and even they say it's ridiculous, that type of word. And I don't know how to control this type of thing. Is there a way I can get some type of help from these universities or any kind of other places for the language improvement? Basically, sound system, recalling particular word in right time, and speaking like coordinating my voice and then my speech speed.
I think a lot of that's going to be focused on using the speech language pathologist
Yep.
to work on that. It sounds like you've had multiple TBIs, so that may have they're going to be the key feature in that.
Mhm.
I can't honestly tell you that the neck has been linked to language type issues or speech type issues in the
Mhm.
sense that you're describing, for sure. I can tell you that the speech language pathologist should be able to do some, if you feel like you're having the other symptoms, the dizziness, the difficulty concentrating, loss of balance, that type of things, then it's certainly worth getting the neck looked at. But the speech centers itself are in a different area of the brain, and they have not demonstrated that the input goes there. So I can't say definitively that it will help you unless you have those other symptoms, to be frank. So, but
And
there are-
Sharman, I have your email, Sharman.
All right.
So we have a speech language pathologist that presented in December of 2021. And she was very, very good about giving techniques and tactics to help people. and hers is not just to slow down your speech.
Mhm.
She has a bunch of others. So I'm going to introduce, she's called the Well Brain. So I'm going to introduce the two of you together. And I've heard this before, where it's perhaps the cranial nerves in your face. And I do not recall which ones it is, but to Paul's point, if you're tensing up your neck, you potentially tense your mandibular, your jaw line up. And if your cranial nerves have been impacted from the injury, the more tension you're causing on your facial muscles in your neck is going to make it harder for you to speak. So I do think that there's a connection, but to Paul's point, unfortunately, someone has not adequately studied it. And this is part of the knowledge gap in traumatic brain injuries. But I will definitely connect you to Taryn, her name is, after this, and perhaps she can help you.
That's great. Thank you.
You're welcome.
Yeah, as you mentioned about that muscle, I mean, face muscles also, yeah, people complaining me, you all the time looks mad and angry. But I myself feel, no, I didn't be mad and angry. Maybe that is the other issue. Yeah, that is good input. Thank you.
Mm-hmm. I mean, and honestly, again, my daughters have TBIs, and so I see it in their faces. I think they're concentrating so hard that they look mad and angry. And I often will say, hey, take a chill pill, smile, right? Just try to relax. And you don't even know that you're trying to focus that hard. So I think a lot of it, and as I even said, how I will do that computer lurch. I forget what you called it, Paul, but like if I had a bad night and my eyes are very tired and I'm like, my face is right in that computer screen. So we all have to be aware of our posture as well too, whether it's facial muscles, gritting our teeth or whatever. But yeah, I will connect you with Taryn for sure.
Thank you.
You're welcome. All right. Are there any other questions? Vicki, did you have any questions that we might be able to help you with?
I'm all set. Thank you. Thank you, Paul. It's a
You're
great,
welcome, Vicky.
Okay.
Good to see you, Vicky. Have a good one.
you too, always.
All right, then with that, we have Paul's contact info. It will be sent out in an email once we get this uploaded to the website. And I will also remind people in the email that we have the potential to get them into a clinical trial with Paul, and you can do it remotely. So it's a one and done. So that might be something of great interest, so that you can actually start contributing to the body of knowledge and also find out if indeed you do have any kind of neck issues going on with your concussion. So without any further ado, Paul, it was a real pleasure. Thank you for being here. And I look forward to having some more conversations with you.
Absolutely. I really appreciate this opportunity to talk to everyone. Thank you very
Sure.
much.
Thank you, Paul. I really appreciate it. Thank you very much.
Good luck. Very much so.
All the time.
All right. Thank you, everybody. We'll be in touch.